Hello anatomy friends, this is Dr. Alsup and we have made it through our good discussion of the bones of the upper limb. Now we are going to talk about the specific joints that are found here, and we're going to start proximally and move our way distally. So we'll start with the shoulder region. And really we're talking about two main joints. We're talking about the acromioclavicular and the true shoulder joint, which is the glenohumeral. But as I am writing out, definitely we will talk about this being the shoulder joint, but this kind of tells you exactly what is connecting here. So starting with the acromioclavicular joint, this is actually going to be a joint between the two bones of the pectoral girdle. So you will have the acromion of the scapula articulating with the clavicle. And it is right here at that articulation that you have the acromioclavicular joint. So this is the one that I said that you could palpate that is close to the point of the shoulder. So follow your clavicle all the way laterally, and then you should feel a fairly prominent bump, and that's about where these two bones are going to articulate. So kind of at that point of the shoulder region. Now this particular type of joint is synovial, but it is a plane joint, which means that there's going to be gliding, so slight gliding of that acromion on the clavicle, which will be a fairly small, these are small movements, but they're important in terms of allowing that part of the scapula to move a little bit in order for the full range of motion that occurs here at the shoulder joint. And if you've ever heard of the term shoulder separation, you would think, okay, I'm talking about the shoulder, so I'm probably talking about the shoulder joint or the glenohumeral joint, but that is not the case. Shoulder separation is actually going to be associated with the acromioclavicular joint, so it's either disruption of the joint or a complete dislocation, as you can see here. So this is the acromion. This is the clavicle. You can see that they've completely separated in this particular image. The shoulder separation is actually associated with the AC joint. Now this can be caused either by a direct blow to the acromioclavicular joint, say falling directly on it or something hitting really hard there, or it can even be caused by those fouche injuries, so that fall from an outstretched upper limb, and that force will kind of move its way up proximally, and it can cause a shoulder separation. Now the degree of the shoulder separation can vary to something that is more of a disruption or a slight disruption to a complete dislocation. And usually, if there is a complete disruption of this ligament right here, your coracoclavicular ligament, you know that that's going to be one of the more severe separations of this joint, the AC joint. Okay, moving to the glenohumeral or the shoulder joint. This is, as you can see, pretty close to that AC joint. It's going to be formed by the glenoid cavity or glenoid fossa of the scapula, and then of course the head of the humerus. And so this is our first and one of our best examples of a ball and socket joint. And I want you to know while we're looking here how shallow this glenoid cavity is in comparison to the size of the head of the humerus. And this lack of fit has a lot to do with the fact that there is going to be increased mobility associated with this joint. In fact, the shoulder joint is going to be the most mobile joint of the body. And that's awesome. Think about it. Try to move your shoulder joint. You can move it in all kinds of different directions, and we'll talk about that in a moment. But one really important concept when we're thinking about joints is that when you have increased mobility, what do you necessarily give up with that increased mobility? You're going to have less stability. All right, so with mobility, you have a lessening or a decrease in stability. So the glenohumeral joint is fairly unstable. There are a lot of ligaments and muscles that are going to play a role in terms of increasing the stability. But the fact that this is the most mobile joint in the body also means that it's going to be one of the most injured joints as well. So very clinically important region of musculoskeletal anatomy. All right. So this is a ball and socket joint, which means it can basically do all the movements that are possible at a synovial joint. So you can have flexion, so this arm is flexing here, or extension. This is extension here. So this is extension past anatomical position. You can also have abduction, or moving away from the midline, as well as adduction. And that adduction can even go past midline. Circumduction can occur here as well, because you can flex, extend, abduct, and adduct. If you add all four of those together, we know that that can lead to circumduction. And then lastly, medial and lateral rotation. So think of that anterior portion of the humerus medially rotating or laterally rotating. So capable of all the joints. This link here should take you to some action videos that are showing these actions. Okay, now let's talk about a few of the structures that are associated with increasing the stability of the shoulder joint. You are going to have this fibrocartilaginous lip, so kind of going over and extending a little bit wider on this portion of the glenoid cavity. You'll even have one that's a little bit going to extend this way. And this is the labra, or the glenoid labrum. These are those lips that play a role in terms of fibrocartilaginous lips that play a role in terms of deepening that glenoid cavity. So you can see that it kind of extends out this way to allow for that head to fit a little bit better in the glenoid cavity region. So remember, ball and socket joints, think labra. Also, really importantly, because this is such a complex area and there's a lot of movement occurring at the glenohumeral joint, you will have some very important bursae that are associated with the joint. I've named two, but they are certainly not the only ones. One right here that's just labeled bursa is going to be the subacromial bursa. And this is going to help facilitate movements of the supraspinatus tendon. And so right here is the supraspinatus muscle belly, and you can see the tendon heading all the way over here to the greater tubercle. And so you're going to have this bursa here between the tendon as well as between that AC joint clavicular region and the bone. So it is very important in terms of trying to reduce the friction that can occur in, say, full range abduction that could potentially lead to pinching or friction of this tendon on these more superior parts of these bones. Now, one bursa that is not here is, so this is the subscapular or subscapularis muscle. It's the only anterior rotator cuff muscle, and we'll talk about those in a moment. But its tendon is going to attach on this lesser tubercle over here, and there will be a bursa kind of underneath this tendon between kind of the neck of the scapula region, which would be right over here in the subscapularis tendon. So help in terms of reducing the friction associated with movement of the subscapularis, and kind of that tendon could rub up against the bone in those areas, but you have that bursa there to help in terms of reducing that friction. So whereas the subacromial or subdeltoid is going to be more superiorly placed, the subscapularis will be more, or subscapular bursa will be more anteriorly placed. And this one actually, this bursa is unique in the fact that it does communicate directly with the joint cavity. Usually the bursae, like we have with the subacromial, are completely separate from the joint cavity. in the joint capsule, but the subscapular bursa does have a communication with it. Now, these are playing a role in terms of reducing friction in these areas, but as there is a lot of movement, and a lot of times with people that have repetitive movements, particularly abduction, flexion, can have inflammation of these bursae, and that these are common areas for bursitis. So that's why we're talking about these two, because they come up a little bit more often clinically. Okay, you cannot talk about the shoulder joint, even though we're not getting into muscles quite yet, but when you are talking about the shoulder joint in terms of what is really creating the stability of the joint and keeping that humeral head where it needs to be in the glenoid cavity, it's really these rotator cuff muscles. And this actually brings up a really nice point that I think it's lost a lot of time in musculoskeletal anatomy. When you're talking about joints, a lot of times you talk about ligaments, and that makes a lot of sense. Ligaments play a big role in terms of the stability in the parts of connecting certain portions of bones to the other part of the bone or another bone, and kind of stopping unwanted movements or adding added protection. But really, tendons can play is huge, if not sometimes a more important role in the stability of joints. And it is certainly the case here when we're talking about the glenohumeral joint. So the rotator cuff muscles are going to be 4 muscles that are the main source of stability of the shoulder joint. And I'm not going to get into the 4 different ones quite yet. We will in the muscles video. But what I do want to note is that these 4 muscles will form an almost complete encircling of the glenohumeral joint region. So it will play an important role in terms of enforcing that articular capsule. It will kind of go beyond that as well. So you almost completely surround the shoulder joint region because you have both anterior and posterior rotator cuff muscles. But one important note is that there will be an inferior weakness in terms of the cuff. So the cuff is almost complete around the glenohumeral joint, except for there's going to be an inferior weakness or an incompleteness of that cuff. And that has implications in terms of dislocations. So when we're talking shoulder dislocation, unlike shoulder separation, shoulder dislocation, we are talking about the glenohumeral or shoulder joint. And so what will happen is that one part of the bone will dislocate from the other. And really it's this humeral head that will be the part that is going to do the majority of the movement. And typically, and let me just kind of label things on this radiograph because I think that can be helpful. So there's the clavicle, here's the acromion, here's the coracoid process, glenoid cavity or fossa, and then of course the humeral head. So in a typical position, that humeral head should be up in this region, right? It should be articulating with the glenoid cavity. But if a shoulder dislocation occurs, most commonly it will occur in an inferior direction, meaning that that humeral head will almost always move inferiorly, which you can certainly see is the case here. But clinically, very rarely are shoulder dislocations described as an inferior dislocation, even though you see a bit more of that as well, and you kind of add it to. But usually when a shoulder dislocation is described, it's either described as anterior or posterior. And that has to do with the fact that did the humeral head move anterior to kind of this bottom portion of the glenoid cavity or posterior? And it is almost always, or certainly most commonly, going to be anterior. You can have posterior dislocations for sure. You can have all kinds of things. Pretty much anything can happen in terms of the human body, but by far the higher frequency is going to be anterior dislocations. And this is often caused by excessive lateral rotation of the shoulder joint or hyperextension of the arm. And that will cause that humeral head to kind of move in this region here. Okay. So this is a big concept and something that I hope we walk away with. But Tell me, true or false, shoulder separation occurs at the glenohumeral joint. All right, so pause if you need to. I want you to focus on this term right here. So where does shoulder separation occur? At which joint? Is it the glenohumeral joint? No, this is false. Shoulder separation is occurring at your AC or acromioclavicular joint, right? Whereas the glenohumeral joint, you can have a dislocation as well as many other pathological considerations that we didn't get into in this video, but really sometimes people get the term shoulder separation and shoulder dislocation mixed up, and this is really going to be more associated with the AC joint, and shoulder dislocation is more associated with the glenohumeral joint. All right, excellent. We will continue our conversation next with the joint, the elbow joint, the joints of the forearm, and then of course the wrist joint or the radiocarpal joint. And then we will move into the muscles. Thanks for your time and attention here. As always, please feel free to reach out with any questions, and have a great rest of your day.